Thanks everyone for joining us this evening. It's lovely to see you. For those who don't know me, I'm Jackie Gambrell, TSA's General Manager. I'd like to start, as usual, by acknowledging the traditional owners of the land and paying our respects to elders past, present and emerging. This always has been and always will be Aboriginal and Torres Strait Islander land.
So Jackie asked me to talk about sleep challenges in children and in TSC in particular. So I'm going to go through things in a fairly broad fashion for you, and then plenty of time to ask questions at the end. So I have a couple of disclosures to just make you aware of. I run a number of clinical trials in a number of developmental disorders. And most of these are sponsored trials, which means the pharmaceutical companies pay us to run the trials. And so that includes cannabidiol, some gut therapies, a couple of sponsored trials in Angelman syndrome, one in Rett syndrome at the moment, and a couple of others that we are running in sleep, not particularly in any disorder. So what I thought I'd talk about is what is typical sleep, because actually I think that's probably one of the hardest things for people to know, what is normal or typical for kids in particular. And what are the things that control and regulate sleep? Because once you understand those, it offers lots of avenues to be able to intervene and try and modify things. The impact is clearly important to families and children, and often just wider than the child. And I'm not telling you guys who live it every day anything new about that, but I can talk to you a little bit about some of the sort of stuff we have good evidence for. There's common presenting difficulties across lots of developmental disorders and common themes that run through. I'm going to talk then about the challenges that we know about in TSC, epilepsy, and ADHD and ASD. So they all interrelate a little bit, and the disorders that we see from a sleep perspective are fairly common across those areas. And then talk to you a little bit about approaches to management. Now, if you don't understand, just jot a note down and come back to it in the question time, because I've gone in some respects in some of these areas to a reasonably good level where you should be able to implement stuff, but there may be things you might not understand. So please don't hesitate to ask. There is no question that is not, able to be asked. So feel free at the end to bring those things up, but jot them down if you do. So what is sleep? Why do we need to sleep? We know sleep is actually essential for function. And if you don't sleep, then actually you die, basically. And you become really, really challenged in terms of body and brain function. So from a body function perspective, a lot of your immunological regulation, your cardiac regulation are all profoundly impacted by a lack of sleep. We know that sleep deficiency is associated with heart disease, high blood pressure, and that's not just obstructive sleep apnea, it's sleep deficiencies as well, stroke and obesity. And it certainly affects how your body reacts to insulin and appetite. And there's some more and more over the last few years, there's been lots more work coming out around that very complex interrelationship between obesity, insulin, appetite, diabetes, those sorts of things. So there's lots more work to do, but very clear there's significant impacts there. And we know that there's lots of impacts on brain modulation, and particularly memory and architecture of the brain. And we think it's probably very impactful on the long-term sort of modulation of our neural pathways, particularly those pathways that are set down to learn and remember, and executive function, that sort of prefrontal cortex stuff where we learn to make decisions and pay attention and focus and those sorts of things, regulate our behaviour. We know that sleep really does impact those areas. We also know that sleep deficiencies affect emotionality, so mood and lability. And those sorts of things are really important. And then at a society level, all of that daytime function in terms of driving, attention, critical tasks, those sorts of things. And we know that if you sleep deprived, you know, it can be worse than having a high alcohol level in terms of impact on driving. So really important to think about. So when you think about that, there's a high proportion of individuals with disabilities of all sorts that have sleep difficulties, up to about 80% at all ages. And autism, or children with autistic-like presentations, certainly feature in that group of disabilities with high levels of sleep disability quite highly. The assessment of these kids is often really tricky and complicated by often significant anxiety, aggression, and challenges, you know, when they're challenged with anxiety, how they react, mood difficulties, sensory difficulties, cognitive understanding. You know, so for example, kids might not understand, you know, validated things that they need to do and thus don't perform on those validated sort of performance things, such as, you know, well, questionnaires are a simple one, but other tests that we might do to try and understand sleep. So for example, one of the tests that we do to test daytime sleepiness, we require a child to actually go into a room and try and go to sleep. Now, that's really only validated for children over the age of 8. So if cognitively you're not in that sort of late primary level, your ability to understand and be able to try and go to sleep as opposed to just lying there is kind of really different. So that test isn't really validated for those people who don't have that level of understanding. Communication is key, and pitching communication, particularly in behavioural modification, is really important to pitch it at the right level. And then there's all sorts of challenging in assessing kids with developmental disabilities in terms of medical conditions. Are they in pain? Have they got gut problems? Have they got a toothache? You know, what is going on sometimes? And that could be really tricky. However, the sleep difficulties are generally very similar across the board, and the approaches that we have to them are usually the same. But it's important that we understand the child and the child's profile to be able to interpret the management options that we have in the way that suits that child. So it's actually not the treatment that changes, but it's the modifications that we make to that with an understanding of the child's developmental and behavioural sort of profile, if you like. What we don't know is the effect of low oxygen, as you might get with obstructive sleep apnea or sleep fragmentation in those kids that wake up a lot. Is the effect on the brain the same for children with developmental disability versus a typically developing population? No idea. Nobody has been able to answer that yet. And there's a group of us that probably think that children with developmental disability, or some of them at least, will have an especially vulnerable brain to the effects of poor sleep. But that has really got a long way to go in terms of understanding that completely. There's also lots of impacts on sleep that come from family dynamics and emotions and sort of management of children that can become very tricky and make it very difficult for us to actually get children to be doing the things that we want them to do at various times. So just a couple of key concepts I wanted to sort of talk to people a little bit about. So it's important, I think, when we're thinking about early sleep problems and early challenges in life, to think about this thing called critical periods of child development. So we know that the brain, different parts of the brain develop at different rates. And it's the same with our developmental skills. And you can see in this slide, say, for example, the orange line, You know, our language develops very rapidly in that first year of life. And the critical period for language is really between about this first 6 weeks through to about 5. So you've got this critical period of language development. If you're thinking about peer and social skills, that's a little bit later, and it comes from about 2.5 and goes through to about 6 or 7. So there's this idea of a critical and vulnerable period for children's development in different domains. And so an injury or something that might happen at a particular point in time might affect different parts of a child's development differently. And that's probably the takeaway message there, that different time points may affect the long-term outcomes differently. So that's a sort of key thing. And I think that's part of the early ideas about treating children with TSC very, very early for their epilepsy and their EEG difficulties, to see if we could, manage that critical time frame for child development. The other really important concept to get across is that children's development happens at different rates, different speeds, and is often not a smooth line. So you might have some children that develop very slowly, you have a kid that develop rapidly, then slow down. There's different ways we all develop, but in general, we're all incrementing sort of forward to the same place eventually. So really important to just think that there are different developmental trajectories and different speeds that we go at different times. So when we're thinking about the impact of sleep disorders, I think there's a couple of things we need to think about. There's really 3 different ways that sleep disorders can impact us. One is the low oxygen, high carbon dioxide that you might see with obstructive sleep apnea or lung disease, so a real respiratory framework to it. And then when you're talking about sleep just in general, you can talk about short sleep, so sleep restriction, okay, versus interruption, which is fragmented sleep, okay? And we often talk about sleep for, non-respiratory disorders as DIMS, okay, or DOEs. So DIMS are disorders of initiating and maintaining sleep, and DOEs are disorders of excessive daytime sleepiness, which is probably not really relevant for this group because they're a separate bunch of disorders. So we know that restriction and interruption can cause problems with mood. It can cause problems with behaviour. So you can get increased irritability, decreased positive mood, and poor regulation, so all over the place with mood. You can get behavioural manifestations, so increased impulsivity, hyperactivity, ups and downs with mood, and inattentiveness. So remarkably, like most of us would call ADHD, really. So very similar symptom profile. And particularly in young children, all of you will know, if you've had children, a tired toddler looks like they got ADHD on steroids. They're running around, they're crazy, they're not thinking, they're up and down like a yo-yo, they burst into tears at the drop of a hat. That is a tired toddler. And we know that probably until late primary, those sort of effects of tiredness on young children will often present in a similar way. But when we start to talk about neurocognitive performance, so this is about the cognition and learning, what we know is that there are certain, it's not as concrete. We don't really get it quite as well. We know that there's less flexibility, so that ability to be able to flex and transition and do those sorts of things sort of dissipates a bit. And that is something that we will often see in kids with autism and poor sleep. So increased rigidity, increased fixatedness, can't shift that set of thinking very well. Kids will often get impaired motor skills. In fact, adults do as well, and decreased attention. In terms of actually IQ, the jury is still well out with that. We really don't know whether, you know, things like obstructive sleep apnea and those sorts of things actually impair IQ at this point in time. It's still a bit up in the air, but we do think these other aspects of learning and thinking impact the learning process. There are other sorts of effects on cardiovascular, immune, and metabolic systems, increased injuries because of that poor attention, and then the effect on the rest of the family, as most of you will no doubt be aware. Usually by just dialing into a sleep conference or a sleep meeting, I know that most of you are affected by sleep challenges. So it is important, and you will understand those impacts. The other concept it's really important to understand is that there are gradations of what we understand is normal. So I don't know how many of you have seen this bell curve, which is what we use a lot in terms of psychology and understanding the human population. So IQ is probably a really good example, but we use it for all sorts of things. So what you might have when you're thinking about say, for example, the amount of hours of sleep a 10-year-old might need. And so what you have is the average, okay? And that's where 50% of the people in the population will need more and 50% will need less, but it's still within normal. And then you might have kids who need 2 hours more, and there's still 2.5% that need more than that, okay? And what we generally accept is that from about here to about here is absolutely typical. And that encompasses about 97% of the population. So that's what we mean by a normal curve. But you can see here, if we're talking about hours of sleep, this person here might need 7 hours of sleep, and this person here might need 11. And still, it's still normal. Okay, so it's really important to understand there's gradations of normal, okay? And we're all actually quite atypical because we have our own little way of functioning. So it's really important to understand there's this curve of what is normal. And so using that curve, people have looked at how many hours of sleep people do need, okay? And this is quite an old study now, but it looked at all the studies across the world, and there was, I think, 20 or 30 in this study, and it amalgamated all the hours of sleep that kids were needing. And so you can see here when somebody is 6 months of age, this middle line here is the average, okay? 6 months of age, then nighttime sleep is about 11 hours, okay? But you can see the sort of maximum end of normal is probably up around 13 hours, and the minimum is about 9, okay? And that actually increases a little bit over that first year of life. And that's because your daytime amount of sleep is reducing and you're getting more at night. And then it gets less and less as you get older, okay? So, you know, when you're 5, an average amount of sleep is probably about 11 hours as well, okay, at night time. But there are some kids who need more and some kids who need less. And likewise, as you go through to adolescence, about 50% will need 8 hours sleep, but there are certainly kids who need 9.5. Okay, so that's that sort of bell curve concept. The other important thing is that, you know, from this study, and this often surprises people, the number of kids who really still require daytime sleeps. So you can see here at the age of 4, there is still 50% of the population needing an hour and a half sleep during the day. And that actually continues out to about 5 as well. So when you think about the amount of kids that we're trying to wean off daytime sleep so they can get to prep at 5, we're actually sleep depriving them during the day. And so this, in fact, is the time when we often get lots of night terrors because we're sleep depriving the kids during the day to get them into a totally nighttime sleep. And so we know that if you're overtired, things like night terrors and sleepwalking and things are worse. And that's why that often happens a lot around that 4 to 5 year old age when you're being pushed to drop that daytime nap. These kids who don't need very much will be fine, but these kids who actually might need 2.5 hours are going to really struggle. And then over time, sleep changes with age, and the proportions of what we call our dream sleep, which is REM sleep, and slow wave sleep, which are probably the two really important bits of sleep for memory and learning, really change over time. So when you're first born, it's about 50%. Then it gets smaller and smaller. And particularly here around adolescence, there's quite a drop off in your slow wave sleep. We think that's really relates to the challenges that adolescents have in going off to sleep. So there's a lot of physiological changes and changes in adolescents' bodies and hormones and things that actually make it really biologically hard for them to get off to sleep at the right time. So I can talk more about that at the end as needs be. But you can see it just gets smaller and smaller. And by the time you're my age, we're starting to get down to very little amounts of sleep. I'm not one of those people. I think I'm in the 98th percentile. Okay, so sleep matures with age, and we think it's likely related to brain maturation. So we know that when we follow EEG changes in development, and most of you will be aware that the EEG matures in that first year of life. And so as that EEG changes, we actually see that directly relating to development and also to sleep. So what we know is that a number of EEG patterns we see in sleep are also related to development. So it's all intertwined, really. That maturity is definitely related to general developmental outcomes at 2 years. So when we look at the EEG in sleep in the first 12 months, we can generally make some predictions, even in the typical population, as to sort of strengths or difficulties they might have with development at the age of 2. Okay. Now, if you're developmentally functioning as an infant or as a 2-year-old, then your sleep is likely to be functioning at the same level. So you might have increased requirements for sleep. You may have interrupted sleep. So you might still, if you're at an infant stage, you might still be needing to wake during the night and have difficulty settling during the night. So it's really important to think about the developmental age as well as what the sleep is doing, and just making sure that we're not sort of implying that, you know, a child who is functioning at an infant stage, we're not expecting them to sleep as a sort of typically developing 8-year-old. So, you know, it's really complicated to think about the impact of those sorts of things. You have this sort of concept of function, and then often there's differences between the concept of function and the emotional level or those sorts of things. So it's about how you pull all of those things together, I think. When we talk about sleep, we talk about the different stages of sleep, and it's directly related, and the sleep stages are described by the pattern of the EEG. So you're starting to see that actually sleep stages are intricately bound up with EEG. So if you've got significant epilepsy or EEG sort of patterns that are odd, it's sometimes really difficult to actually get clear sleep stages and really difficult to transition between sleep stages. So what we know is this is an awake EEG. This is when you're really drowsy, you know, you're sitting on the couch and you might be watching something and you don't really remember what you've been watching, but actually when somebody wakes you up, you go, yeah, I'm awake, you know, so it's that sort of drowsy stage. Then you have what we call stage 1 sleep, where you're just starting to get really sleepy. Stage 2, which is where we see these little caterpillar-like things, and then slow wave sleep, which is these big waves. and then REM sleep, which is your dream sleep. So these are all the different patterns we see, okay? And what happens during the night is that you cycle through stages, okay? And this is a typical sort of pattern that we see for sleep in children. So you go from awake, and then you go into that light sleep, then you go into stage 2, and then you go into deep sleep, which is those big waves that we see. Then you come up out of that, and you might go into a little bit of dream sleep, and then cycle back down. And each of these is about 60 to 90 minutes, depending on how old you are. So it's what we call a sort of ultradian rhythm, but it's about 60 to 90 minutes where you do this. And what is really important about this slide is that it shows you that often when you come up through this cycle into the dream sleep, you get an awake period, and that is completely normal, okay? So we expect up to 4 to 5 wake-ups during the night. And for most of us, particularly the mums and dads, you know, what you will do is you'll open half an eye, you'll be half asleep, you'll sort of half, you know, cogitate, okay, everything's the same, I can't hear anyone crying, and then you'll slip straight back into sleep, and you might not even be aware that you've woken up. Okay, where this tends to become a problem is if kids wake and everything's different, and then they're wide awake trying to settle back down. Okay, so it's about keeping these wakings really brief and minimum, okay, but it is normal to have those wakings. And you can see by the 60 to 90 minutes, okay, it's really important. So the first question a sleep physician might ask you is, okay, so what times do you wake up? And I can guarantee that if you're going to bed at 9, the first one's likely to be 11:30, then about 1, then about 3, 2:33. And so you can time these wakings. And actually, if they're fitting that hour and a half sort of cycle, I know that child is following a normal sleep architecture, arousing at the right time, but maybe just not settling back quickly enough. Okay, so some of the control sleep, okay, and it's important to have a good understanding of this. Okay, one is circadian rhythms, and that's that daily cycle that we all go through. And I think most of you will have heard a little bit about circadian rhythms. The other thing that we have that controls our sleep is actually, you know, believe it or not, how long since you've last had deep sleep. So, you know, that is, you know, it seems a bit logical really, but it's called this process S. So that's how sleepy you get depending how long you've been up. And that's the thing they think adolescents are less sensitive to. So it takes them longer to feel sleepy when they've been up, and that's part of the drive. And then there's hour and a half sort of cycle that we have. The reason the hour and a half cycle, and I'm digressing a little bit, is really important is that if you're trying to, this is a sort of map of it, and we all do this. So you have that period when you wake up in the morning and you're bright as a button, and then you have a slump about mid-morning, okay? And that's when you should be having your coffee. So you have that slump, and then you pick up a bit, and then you have a slump again after lunch. So it's about that sort of hour and a half sort of cycle. And so if you are a sleepy person like me, you need to time your coffee for the slumps, okay, to actually get that sort of maximum alertness, if you like. And so this is more of an alertness type thing. The trick with that one is that if you're going to try and go to bed at the wrong time of that cycle, you're going to be sort of alert. And most of you will know you'll feel absolutely exhausted at a certain point in time, and then you'll just finish something, and then you'll go to bed and you'll be wide-eyed and you won't be able to get to sleep. And that is because you go through the wrong part of that cycle. So the trick is to actually get up, do something fairly bland for half an hour, and then try again to get yourself back into the right part of that hour and a half cycle. So that sort of explains some of that adult insomnia stuff. Okay, so that is where that sort of hour and a half thing fits in. So we know that 80% of children with an autistic phenotype or autistic presentation will have a sleep problem, and about 50% of kids with a diagnosis of ADHD. So kids with TSC that have a combination of some of these things are really highly likely to have sleep problems. So just coming back to that daytime thing, most of us will have a daytime cycle, and a circadian just means around the day. And it's generally controlled from a small little gland right in the middle of the brain. And it's really controlled a lot by a sort of innate cycle that goes in about a 24 to 25 hour sort of cycle. So it's not exactly a full day. Okay, it's not exactly 24. It's usually a bit more than 24 hours is the natural cellular cycle. But what happens is that the light that comes in to the back of our eyes actually controls that and brings it back to a 24-hour cycle. So that's why it's much easier to stay up later than it is to go to bed earlier, because we naturally have a 24.5-hour cycle or a 25-hour cycle. But it's what we do with ourselves in our routine that keeps it in a 24-hour cycle. So that means sort of regular routines around light, eating, getting up, darkness, showering, those sorts of things. The routines are what keep us in a 24-hour cycle, not necessarily our innate rhythm. And that's a really important concept, I think. I'm going to skip through that a little bit. It just talks about some of the things that control that circadian cycle. And we have lots of genes that control it. The light that controls melatonin release sort of manages that cycle as well. The behaviors that we do, so when we sleep, eat, drink, etc., control it. And those ultradian, which are the hour-and-a-half cycles. And then there's a number of other hormones that control it as well. Now, that's all research that's been done in typically developing brains. We really don't know how it sits with an atypical brain. And for some, that means that we get very dysregulated cycles, possibly longer cycles. We know that with vision impaired people, it can be really tricky to establish some of those cycles. So really understanding the typical is important first, but then we need to work with specific groups of disabilities to work through. And when we talk about regulators of our cycle, and this is really important for all kids, and particularly those kids that are a bit dysregulated, so light is really important. So in the evening, to get off to sleep, we need exposure to dim light, okay? So sitting in a really bright room, playing lots of games without dimming sort of on the screen, with lots of blue light in particular, blue and white light, is what tends to suppress our melatonin and make it harder for us to get off to sleep. Okay, so light is really important. And bright light in the morning is what really stops our whole cycle slipping. So what we should be saying is that there's dim light in the evening and bright light in the morning. Okay, behavioral entrainment, routine. Can't say routine enough. We need to be doing the same setup before we try and go off to bed every night, okay? And trying to get those routines in pattern. So whether it be eat, shower, teeth, bed, book, bed, you know, whatever works for the family, but trying to get it at the same time and in the same order will be really key, even if you sort of slip it by half an hour, so long as the order's the same. Food is really important. So we know that kids that are fed overnight through nasogastric tubes and things will often have very disturbed sleep. For kids that get lots of constipation, you get very disturbed sleep. So making sure that food is appropriate and given at the right times, and preferably as typically delivered as possible. So if you're on nasogastric feeds or something like that, trying to move towards boluses as much as you can and feed times rather than overnight feeds. There are circumstances where you have to do overnight feeds, and that is fine, but it can really disrupt sleep. Temperature is another one. Okay, so to actually get off to sleep, one of the things our bodies do is actually drops our core body temperature. So we get cool. Okay, so our core, so the central body gets much cooler. And that's why we will often recommend a warm bath, because what happens in a warm bath is the blood vessels in your skin dilate. Okay, then you get out of the bath into the cooler air, and that blood temperature automatically drops and takes it back to the center of your body. So you get a drop in your core body temperature, and that in itself can be very sleep inducing. So it's not the warm bath per se, but it's the fact that the warm bath opens up those blood vessels and allows that coolness to come back to the central part of your body and changes your body temperature. It's that change that's really important. So that old wives' tale of having a warm bath before bed actually has a lot of good science behind it, okay, as often old wives' tales do. So that's a good one. Genetics, we know there's lots of regulation there. I'll show you a slide, but I'm not going to go into it too much. Age is really important. And the other things, which is something that kids with TSC are often dealing with, is seizures and abnormal EEG can really impact that regulation of sleep. So that's just a picture of the complexity of the genes that control. This one up here is the genes that control the daily rhythm. And this one just shows all the different cells in the body that have that daily rhythm. That's just another model of how those genes interact. And I'm not going to go into it more than that. It is really complex and probably a little bit more than I can understand sometimes, but suffice to know there are lots of genetics that do interact with that. And some of these clock genes are in fact interrelate with some of the other genes involved in the mTOR pathways. So in the sort of broader sort of spectrum of genes that interact in that mTOR world. So just to say, there's lots of different genes that change. And we know that for kids with autism, about 1 in 4 of them will have some anomalies or changes in some of those genes that affect their sleep regulation. So when we come back to sleep in general, okay, we talk about difficulties initiating sleep, difficulties maintaining sleep, disorders of sleepiness, which is what hypersomnolence is. Now, we often see hypersomnolence in kids that haven't had enough sleep, or they've had disrupted sleep, or they have other reasons for not getting enough sleep. And so when we talk about a disorder of sleepiness, we actually mean those kids that are just innately sleepy all the time and actually get good sleep, but are still sleepy. So it doesn't really fit as much in this circumstance. I'm not going to go much into that. The important things are probably some of the medical issues that we need to actually manage really well to maintain sleep. So if you've got asthma, we know that will disrupt sleep. If you've got eczema, some of the kids with the worst sleep I've ever seen have just had terrible eczema, and trying to actually sort their skin out so that the kids can get enough sleep has been really important. Epilepsy is key. So it's not just epilepsy, it's also the medications that are used in epilepsy that tend to either make you sleepy during the day, but you need them for control during the night. And it's a really fine tightrope to try and work. But trying to maximize things so that you get a good consolidated night's sleep is really important. It's really important for consistency in how we manage behavior, particularly around sleep. And then those disorders, or those groups where there's a high risk of sleep disordered breathing. So those people with obstructive sleep apnea. And obstructive sleep apnea in children is often, due to facial structure. So if you've got both parents who use CPAP and have obstructive sleep apnea, it's very likely the kid might as well. So thinking about those sorts of things. So if the child snores a lot, it's probably important to get that looked at. Then we have lots of susceptible groups or personalities, if you like, I like to call them, you know, ADHD type of presentations. Those sorts of kids will often have a lot of difficulty in settling and calming. And when you think about going off to sleep, you actually need to feel safe and you need to be able to calm and relax to be able to do that. And so kids with ADHD are often a bit wound and really have trouble in being able to calm down enough and still enough to be able to get off to sleep, particularly those kids that are on short-acting medication, because you have that calming of the medication during the day and you have a bounce in the evening, and then it can become really difficult getting off to sleep. Likewise, kids with autism that have a lot of hyperactivity as well. Okay. The good news is that some of that hyperactivity often settles down as you go through adolescence. So that's the good news, really. Then lots of different developmental delays. So kids with vision impairment impacts the melatonin. Physical impairments can impact your sleep because that inability to roll, those sorts of things, seizures. And then lots of different disorders may have slightly different manifestations. When you think about assessments for sleep, what we do is we look at all the medical things. Reflux is a biggie, actually. Those kids that have had gastroesophageal reflux often need treating. So we can ask questions of the parents. But if, you know, I had to think about probably the most important technical thing in the last 5 or 10 years from a sleep physician's perspective, I think the invention of the smartphone, that you can take home videos and show me how your child breathes at night, is probably been the most helpful thing. So if your child is doing odd things at night or breathing in an unusual way, take a video and take it with you to the doctor, because that is probably one of the most useful things we can do. Actigraphy, which is where we get kids to wear wristwatches, a bit like a Fitbit type thing, and that will give us a pattern of how the kid is sleeping. And this is an example of a kid who was just sleeping all over the place, and then we treated and got them into sleeping in a regular pattern. Okay, we can do assessments at home, in hospital, we can measure oxygen and do all those sorts of things. Some of those are really tricky for kids, because a sleep study will often involve EEG leads, as well as things around their chest and things under their nose. I'll show you a picture in a little bit. But for some kids that have a lot of sensory challenges, that can be really difficult for them. And that's where things like video and things can be helpful. When we think about all of these things and relate them back to kids with tuberous sclerosis, when I did a quick scan of the literature, which I haven't done for some time, I might add, you know, it was really obvious to me there hasn't been a lot of work done in understanding sleep difficulties in tuberous sclerosis or kids with tuberous sclerosis complex at all, really. There's been some questionnaire work, okay, but very little. And most of what was there was actually quite old. So what they did know is that the kids that have sleep problems with tuberous sclerosis, it's most commonly associated with current epilepsy, so current epilepsy status, and those kids with high levels of behavioural disturbance, okay, but not necessarily levels of developmental delay or parental stress, which is a little bit unusual compared with other groups. But it's that current epilepsy and high levels of behavioural challenge that I think is probably the most evident for us. Autism and dysregulation were also related, but those milder forms of developmental delay or sort of global delays were not related to sleep difficulties. In another study that was done several years ago, it was quite clear, and this was a study that measured the EEG and looked at the levels of each of those sleep stages. What they found was that children with tuberous sclerosis had quite a significant reduction in total sleep time. They had more difficulty in getting between sleep stages. So transitioning, you know, in that little diagram I showed you of going from 1 to 3, up to REM and down again. So each of those changes would be disrupted and they might wake more. And they had less of that REM sleep. So REM is that dream sleep where you lay down a lot of memory and working memory in particular. So and this was much worse when seizures were active. So coming back to that idea of current active epilepsy. So those sorts of things are really important to think about. Sleep alterations were much more obvious. So those kids that had a large bilateral tuber load in the frontal and temporal areas of the brain, as opposed to the cortical and posterior. And that kind of fits because the frontal and temporal areas are where a lot of our emotional and hyperactivity stuff sits. And so it kind of works, I think. Again, a really old paper, and we probably need to revisit it in light of, current treatment sort of paradigms that we use, which are kind of a little bit different to back then. Interestingly, melatonin study improved total sleep time, but only by about 30 minutes, so not a huge amount. But didn't really change how much kids woke up. Now, that is probably been borne out fairly solidly over the years, and there's no data to suggest that anything is different in general developmental disabilities and melatonin. It's really good for helping people get off to sleep, but doesn't help maintain sleep. And when we think about how many kids have problems, what we see is probably about kids with tuberous sclerosis having probably 2 to 3 times the amount of sleep problems that a typically developing population would have. And that for kids with tuberous sclerosis, those that did have sleep problems were more likely to also have hyperactivity and dysregulation. Now, it's a bit chicken and egg. Is the sleep problem causing those things, or are those things causing the sleep problem? And that study didn't answer those questions. It just said that they would often have both. So, okay, what do we do about it? This is probably the bit most people have been waiting for a little bit, but I think it's important to understand all those bits first. So the first thing is really to establish good sleep habits. And we know that by doing this, we can actually sort sleep problems out for kids with autism, with kids with ADHD, and about 20 to 30% will be cured simply by doing good sleep habits. And so that's about teaching a child to be able to calm, be able to settle down, by feeling safe, doing really good things around that sleep entrainment. So getting that day different to night, managing dim light, bright light in the morning, busyness versus calmness before bed, noisy during the day versus low noise or nil noise at night, routines, and then consistent associations with sleep. So always doing the same thing and going to bed in the same situation. So this comes into when I'm going to talk about sleep associations in a little bit. The way we go to sleep at the beginning of the night should be the way we sleep all night. So if you go to sleep on the couch with the TV on and everybody around, it's quite noisy, and then you wake up in your bed and it's dark and it's quiet and nobody's there, you wake up in those transitions, you'll wake up, you'll be wide awake, and you'll not be able to settle down until you recreate how you went to sleep at the beginning of the night. So it's about that consistent going to sleep in the same way every night, calming activities. And we know that, and we call that sleep hygiene. We know that, that is really important and will actually sort out sleep initiation problems for around 30% of kids with autism and ADHD. There's really good evidence about that. So I can't emphasize that enough. It's really important. Then what we need to do is rule out any sort of other disorders and treat those sorts of things. So respiratory disorders, so if you're snoring, we need to rule out obstructive sleep apnea, sort out tonsils. If you've got eczema, we need to treat that. If you've got reflux, we need to treat that. We need to get the seizures under the best control we can. Okay, so all of those things need to be done. And then if we're still left with behavior, with what we call behavioral disorders of initiating and maintaining sleep, that's when we need to start to put specific behavioral management things into play. Okay, and so when you talk to sleep doctors, they'll talk about different disorders, and they're just labeled by their patterns, really. So we have one thing that we call a limit setting disorder. And this is where a child has difficulty falling or staying asleep. But it's those kids who actually refuse to go to bed, and they come out with excuses, and they, you know, one more trip to the toilet, or they need another glass of water, or, you know, it's that stalling, you know, and they're often, there's a bit of fear of missing out in some of these kids because they actually want to be involved in something and they think they're missing out. And it's a bit of a trap for us as parents sometimes, because we've been so worried about our kids. Sometimes we let them get away with stuff for a while. And I always say to families, it's really important to actually stick to your guns, no matter your child's disability, because that routine is absolutely important. So really sticking to a good pattern and really making your expectations really clear about that. So that's the child who stalls and comes in and out, and sort of sets the routine a bit. Then we have sleep association disorders. And this is where a child associates going to sleep with a certain set of conditions. And I guess for most of us, it's a bit like, you know, you used to sleeping with your partner or with a child or something in the bed, and then maybe your partner's staying somewhere else or something. And, you know, when you wake up, oh, something's a bit different. Okay. But us as adults, we can sort of process that, oh no, things are a bit different, but oh no, he's away at a conference. It's okay. And we can go back to sleep. But a child doesn't process that during the night. So if something's different, they will be immediately alert and come to you trying to get that situation back. So they can often be quite problematic, because what happens is that going off to sleep requires that particular set of conditions, and that's a habit. But then every time they wake during the night, they're going to want that set of conditions recreated. So that if somebody falls asleep in your arms at the beginning of the night, then they're going to want you to come back and go to sleep in your arms again during the night. So often the focus for sleep association disorders is actually really about working on the beginning of the night, because we're all far too tired to try and do it during the night. Really working on the beginning of the night and setting up those sleep associations that don't require your intervention or presence. So if you can get your child falling asleep on their own in the beginning of the night, then you'll find the rest of the night will sort of sort itself out, because they'll be falling asleep. They'll be waking in the same condition they fell asleep. And, you know, that's one of the reasons we try and say to mums, you know, very early on, when you can nurse your child and cuddle them until they're just about to fall asleep. But as soon as you see they're almost, put them to bed while they're still awake, so they actually go to sleep in that environment and they're used to being in that environment. So put them to sleep or put them into bed while they're still awake, even if they're sort of in that drowsy phase, so they're aware they're in that space. And that is a really important way of moving that. There is lots of behavioural things I'll talk about in a minute about how to sort of manage that a little bit. But where it gets really problematic is where, you know, you need a parent to come in to recreate that same situation each time. Okay. It's very similar in some respects to separation anxiety, particularly where a parent's involved. So a child who really needs a parent present to be going off to sleep. And for some kids with seizures and things, or trauma from being in hospital, that anxiety about separation is very real. And it's about how we manage that anxiety and support kids through that phase to understand that they can actually go off to sleep on their own. Okay. It can get really tricky, particularly around that 4 or 5-year-old age group, when you've got kids actually starting to develop normal fears, normal, fear of the bogeyman under the bed, or, those sorts of things. They're all very normal things that 4 and 5-year-olds come through. But if it's then combined with a bit of trauma of having been in hospital and worry about seizures or not feeling right, then you can get into quite a pattern where, the child really needs you there to go off to sleep. And that's where it gets really tricky to try and manage and try and teach that kid to get off to sleep. So there's different things we can do. And you may find these kids might have a lot of difficulties on sleepovers, those sorts of things. And, we need to work through it. So there's good evidence around different sorts of treatments. And so you can do, in older kids, you can do some cognitive work with psychologists around nighttime fears. You do the sleep hygiene we talked about. You can do different sorts of things. So you can do something called graduated extinction, and that's where you separate slowly from the parents. And that's where, you might sit in the room instead of lying in the bed and gradually move yourself towards the door and then out the door. Often it's getting from the door to out the door that it becomes the problem. Okay. Yeah, exactly. Sneaking through. One of the things we use now instead a little bit is this sort of technique we've termed checking in and checking out. So what you do is you get to the door, you're fairly separate, kids looking really drowsy, yes, and then you say, I'm just going to get a drink from the kitchen. I'll be 10 seconds. You go out the door and you're really only 5 seconds, in and out, in and out. Because what that child has to learn is to feel secure that you will come back when you said you were going to come back. And so it might be 5, 10 seconds and you come in and out for a little bit. And then as time goes on, and it may take weeks, as time goes on, you make that time longer and longer. Dad's just got to go and do the washing up. He'll be back. I'll check on you when I've finished the washing up. You stay in bed. Never tell kids, actually, by the way, that they get rewards or they have to stay asleep, because you can't control staying asleep. You can actually control staying in bed, though. And so that's what your rewards and your behaviour management should be about, staying in bed. You stay in bed, rest your eyes. I'm just going to do the washing up. I'll be back. And so once the child learns that you're going to always come back and gets that reassurance, and different kids will have different levels of anxiety, once they learn you're going to come back, then they'll start to relax more. And sooner or later, they'll fall asleep on their own while you're outside, and then you've cracked it. You then need to just build on that and continue that for a little while. And then the child will start to be able to feel comfortable going off to sleep. But you might need to promise that you'll check in on them before you go to bed, that sort of stuff. And that will usually get you through that sort of hiccup in getting out the door, so to speak. Okay. We know that bedtime fading can sometimes be useful. So this is where kids might be put into bed a little bit earlier than their natural sleep cycle might be. And how do you work out what is a normal bedtime for your individual child? And so we do sometimes do something that we call bedtime fading. So that's where you set a morning time. So whatever time you have to have everyone up in the morning, that's your wake up time. And then what you do is you guesstimate where that child should go to bed. Okay. And it might be 10 hours or 11 hours sleep. So you pick a bedtime. And then if the child takes more than 30 minutes to get to sleep, okay, the next night you put them to bed 30 minutes later. Okay. And then if they take more than 30 minutes, you put them to bed 30 minutes later. if they fall asleep in under 15 minutes, you put them to bed 30 minutes earlier. So you shift it around until you find the right bedtime for that child. And that's called bedtime fading. You can look it up. There's it's a really useful thing to try and find the right time for your child to get into bed. Does it make sense? Okay, so that's bedtime fading. Sleep hygiene we've talked about. Positive bedtime associations is another key factor. So that's where the bedroom is actually a positive place. It's not where you get sent to cool down from when you've lost it. It's not where you are sent as a punishment, those sorts of things. So if you're doing some, you know, time out type things, don't use the bedroom for it. Use the laundry or a step or something, but don't use the bedroom, because the bedroom needs to be a really positive, calm place. So it's where quiet play can happen, not rambunctious, you know, those sorts of things. Just try and keep it really quiet and calm. And then lots of praise around establishing routines, bedtime behaviours. So for example, today, I saw a little girl who was 4 with autism and ADHD and non-verbal. She said lots of trauma and other things go on. But the positive, the real flip in how she started to get it was getting stickers, obviously. And remember, stickers don't work much before you're 4. You need to get to that point where stickers are actually important. So sticker charts, if you use them too early, they're not going to work. Okay, so it has to be something that motivates a child. And then you need to have something really concrete, okay? Because a child to achieve positive rewards, they really need to actually be able to achieve it. So if you make it too hard, they're not going to do it and they'll lose interest really fast. And it's, you know, so if you say to somebody who's never slept in their own bed for more than half an hour and it takes them 3 hours to get to sleep, you get a sticker if you sleep all night in your bed. They've got no hope, okay? And so it's not going to work from the very get-go, no matter how interested they are in stickers. So what it needs to be is something really simple, like we're going to get a sticker for you being able to go and lie in your bed. End of story. And so you keep it really simple. Even if they only lie there for 10 minutes, you might even start at that. So it needs to be really simple and it needs to be something they can achieve. Okay, so this little girl, for example, is now only waking up once a night and coming in and getting a parent to take her for a drink, etc. So we've now moved on from her getting a sticker for going to bed in her bed, which was the first step, to now she's going to have to stay in bed all night and not wake mum. So, you know, you then every 2 to 3 weeks, you need to up the ante a bit so they don't lose interest. And so it's, and just make it slight. Once they've achieved something, you need to move very quickly to the next layer and the next level. So that's a really important thing to just think about and make it something really tangible. As I said, don't reward kids for sleeping because they're not going to be able to sleep. It's about staying in bed or not waking the others or those sorts of things. So really important to think about that. And really, if you need that extra assistance, just seek out some additional training or something. You know, people say raising kids is natural. It's not. It's something we all need help with from time to time. And I think if you're really struggling in knowing where to go, don't be afraid to ask for help. You know, particularly some of the sort of sleep nurses and things can often really be quite helpful in that space. How am I going for time? Over already.
About 20 minutes left, honey.
Okay, I told you I could talk under wet cement. So camping out's where you're actually sleeping in the room. So that's about setting up that sleep association. And so if you've got a kid who's sleeping in your room, the first thing you need to do is get them sleeping in their room, and you might need to move into the room with them while they get used to that new set of circumstances. And that's where you need to sleep on another bed in the room. I try not to sleep in the same bed because sleeping up close to someone makes it harder to do that separation later. So sleep in a mattress on the floor or something else. And then you tie that in as you're trying to get out the door with that checking in thing. The only thing, that's the checking method. The other one you can use in fairly able kids is a get out of bed card, where you make a card up, and little boys that like football really like this one, because you can give them a red or a yellow card. And what you say is that every time you get up, we get the card. And so you might start, for kids that get up a lot, with 2 cards. Okay, so if you get up, I take a card. You get up, I take the other one, and then you can't get up anymore. So you only have 2 options for kids, you know. And what you find is they might use the first one, and then they're so worried they might need the other one to get up and go to the toilet, they actually don't get up again. And so you use those cards to actually try and get them to stay in bed. And that could be particularly useful for that limit setting, where kids are doing that stalling, coming in and out quite a lot. You give them a card. Okay, you can get up once, but once you get up, I take the card, and that's your only opportunity. There's no other opportunity to get up, and you find they save it. It's a really neat trick, that one. Okay, so that's just the light. I'm not going to talk about that. Autism, we've talked about a bit. This is just this picture here. That's sort of the EEG leads and what's involved in a sleep study. And just remember that for kids between the ages of 2 and 6, it's where the tonsils are often biggest. So if kids are snoring at that time and getting disrupted sleep, it's always worth getting that looked at. Okay. We've talked a bit about that. Talked about those things. This is more of the same, really. I like this one, and this works well for those kids who and typically developing kids actually as well, but particularly those ASD kids who ruminate. They like to go over everything all the time. And I love this little cartoon. 3 out of 4 voices in my head want to sleep, and the other one just wants to know if penguins have knees. And you know that you can all do that when you're thinking through that stuff that's in the night. And this other one, you know, blanket on, too hot, blanket off, too cold, one leg out, you know, everybody is different. Okay. We sometimes find that sensory kids like to sleep in enclosed spaces. So don't be afraid of trialing little tents or something like that. I'm not going to go through that. Remember pain in kids, particularly those that are significantly disabled and can't express pain very well. And we know that in some developmental disorders, a lot of presentations to emergency departments and to doctors is actually about behaviour, but it's actually about pain, and it varies. Everybody interprets pain differently. So changes in demeanour, more or less irritable, quieter or louder, these sorts of things may often indicate pain to us. Remember, there's lots of different communication methods we can use. A lot of pain scales are now pictorial, so you can start to think about how your child interprets pain. And then what might it be? Is it reflux, fractures? Not so much in the TS group, but there's a couple of disorders where they have a high incidence of bone disease. And we've had kids present and been found to have hip fractures and all sorts of things that have been unrecognised for a while. Headaches, teeth, ears, those sorts of things. Okay, and I'm not going to talk about adolescents because I want to leave time for a couple of questions. So I might finish there, but I'll let you have the rest of the slides. Is it 1 or 2 slides there about parasomnias and night terrors? And probably the biggest trick there is that they're pretty normal, having those sorts of things. And the best thing you can do is make sure kids are getting enough sleep, because if you're overtired, they're worse. And most kids get that sorted by actually having a bit more sleep.